Good morning and welcome, my dear medical students. In this lecture on Japanese encephalitis, the Japanese encephalitis is a disease caused by a virus and it is spread by bite of the Culex mosquito, mainly the Culex tritinio-rhynchus. So, Japanese encephalitis. Cephal. The meaning of this cephal is brain, or initially it was used for the head. So as the name indicate, it is a disease of the brain, or I can say the disease of neurological system or neurological dysfunction. So Japanese encephalitis is caused by a virus known as Japanese encephalitis virus, JEV. It is a member of Flaviviridae family. It shares the same family of the dengue virus fever and some other arboviral viruses. So it is also an arbovirus, and it maintains its own cycle by the mosquito, bird, mosquito, and the mosquito, pig, mosquito cycles, and it causes the same disease in piglets, not in pigs, and horses. So same disease, signs and symptoms are caused in horses and piglets. So the Japanese encephalitis virus is a member of Flaviviridae family, and it maintains its own cycle by mosquito, bird, mosquito, and mosquito, pig, mosquito cycles, and it is caused by the Japanese encephalitis is caused by the bite of the night bite mosquito, the Culex, especially the Culex tritinio, rhynchus. The Japanese encephalitis is mainly a disease of Asian rural population. So in Asian rural population, it is caused by bite of Culex tritinio-rhynchus mosquito, and the mosquito bite transfer or transmit the virus from mosquito to the human being. There is no human to human transmission of Japanese encephalitis is seen, but there is trans-ovarian spread of the Japanese encephalitis virus is seen, and it is very, very dangerous for the developing fetal during first and second trimester. It is not seen, the trans-ovarian route is not seen in dengue virus, but it is seen in case of the Japanese encephalitis virus. So it is caused by bite of Culex tritinio-rhynchus mainly, but in some Asian countries it is also caused by bite of the Culex vishnui, especially in India. Culex vishnui in India, and the other species of the Culex, that is the Culex tritinio-rhynchus and Culex gelidius. Especially in Thailand and Indonesia. The Japanese encephalitis is presented as simply, or I can say subtle behavioral changes and the atypical febrile illness, but it may be having, or it may be presented as the severe neurological manifestations like the blindness, ataxia, movement disorder, and the weakness. So the Japanese encephalitis infection, in maximum number of cases or in dominant cases, it is at the level of subclinical infection. Only 1% of the infected persons, 1% out of 100 is having the clinical signs and symptoms like the atypical febrile illness and light neurological signs and symptoms, but 1 out of 250 infected person is having serious neurological manifestations like the encephalitis. The Japanese encephalitis virus is a member of the Japanese encephalitis serocomplex family, which is having about 9 genetically and antigenically close virus family. The other members of the Japanese encephalitis serocomplex are Alphuia virus, the Alphuia virus, the Cassipacor virus, The other members of the Japanese encephalitis serocomplex family is Japanese encephalitis virus, the Japanese encephalitis virus, the Koyo Tango virus, the Koyo Tango, the Alfuya, the Cassifacor, the Japanese encephalitis virus, the Koyo Tango virus, and the Murray Valley encephalitis virus, the St. Louis encephalitis virus, Yushu2 virus, and some other viruses like West Nile virus. So, Japanese encephalitis serocomplex family of viruses which are genetically and antigenically very close to each other are having the Alfuya virus, the Cassifacor virus, the Japanese encephalitis virus, the Koyo Tango virus, the Murray Valley encephalitis, St. Louis encephalitis, Yushu2 virus, and the West Nile virus. These all are members of the serocomplex Japanese encephalitis family. The pathophysiology of the virus after bite of the Culex mosquito. So, Japanese encephalitis virus pathophysiology. After bite of the mosquito, that is the mosquito of Culex family, and sometimes, rare times, it is also transmitted by bite of Aedes mosquito, especially in Asian countries. In American countries or in North America and European countries, there is no history of bite of mosquito infected by Japanese encephalitis, but it is imported by travelers traveling in the Asian and other endemic countries of the world. So there are two proteins, M protein and E protein. The cell is having two proteins, the M protein and the E protein. After bite of the mosquito, the virus is injected in the epithelium of the person or the infected person. Then the M protein is hydrophobic protein. It is having hydrophobic and which anchors the virus to the cell wall, especially to the cells of the lymphatic system. So virus is anchored by the cell wall by the hydrophobic end of the M protein. Now, E protein. E protein plays major role in the envelope fusion of the virus to the cell wall. So this is envelope of the virus and it is the cell membrane. The fusion of the envelope of the virus and the cell membrane is supported by the E protein. After its entry inside the cell, this genetic material of the virus, that is Japanese encephalitis virus, single stranded virus, this genetic material fuses with the genetic material of the cell and the virus multiply and mature inside the cell, especially inside the Golgi apparatus. So inside the Golgi apparatus, then the virus multiply and mature. After this multiplication and maturation, the viremia is spread to other parts of the body, especially the lungs, liver, heart, and reticuloendothelial system, that is the RE system. And in very few cases, it is spread to the central nervous system, but in maximum or in the many cases, the viremia is spread out before it is neurotoxic or neuroviremic to the central nervous system. So 1 out of 250 cases of the Japanese encephalitis virus infection are having the serious neurological complications. In research, advanced research, it has proved that the matrix metalloproteinases, so metalloproteinases, the matrix metalloproteinases and metalloproteinases have played important role in the infection of Japanese encephalitis virus, especially this matrix metalloproteinases and anti-metalloproteinases have destroyed the endothelium of the blood vessels of the central nervous system, and these are also involved in destruction of blood-brain barrier and blood CSF barriers. So the matrix metalloproteinases and anti-matrix metalloproteinases have also played important role in the viremia and especially the Japanese encephalitis. The signs and symptoms. the signs and symptoms of the Japanese encephalitis. The signs and symptoms of the Japanese encephalitis may vary from the asymptomatic infection and simply febrile infection to the very serious neurological manifestations, especially the brain and the spinal cord are involved. So it is having the prodromal symptoms. The incubation period of the Japanese encephalitis is 6 to 8 days. 6 to 8 days, but it may vary from 1 to 14 days. The calculation of this incubation period is having great importance in the patients which are traveling the Japanese encephalitis endemic areas. So prodromal features or prodromal signs and symptoms are fever, headache, the nausea, the diarrhea, the vomiting, and the myalgia, that is muscle pain. So the prodromal symptoms are fever, headache, nausea, diarrhea, vomiting, and myalgia. After this prodromal phase, there is the phase of the neurological involvement. This neurological involvement may also vary from simply changes or subtle changes in behavior to the serious complications like blindness, ataxia, movement disorders, and weakness. After this period, there is altered mental status, altered mental status. So after fever, headache, nausea, diarrhea, vomiting, myalgia, there is altered mental status, followed by seizures, especially in children, followed by seizures, flaccid paralysis, here the patient of Japanese encephalitis may mimic with the Guillain-Barré syndrome. The extrapyramidal symptoms